Hello students. Today we are going to discuss about pharmacology of estrogens. Estrogen is also known as female sex hormone. It is produced by ovaries by developing follicles or Graafian follicle into the pre-ovulatory phase, and into the post-ovulatory phase corpus luteum also secretes small quantity of estrogens. Placenta secretes estrogen during the pregnancy, and small amount of estrogen is released by adrenal gland and testes also. Chemically, estrogen is a steroid. Typical estrogenic activity also by non-steroidal compound is seen. So term estrogens is used as a common term to describe all the compounds having estrogenic activity. Estrogen is a hormone which is released endogenously. It is a female sex hormone, and there are synthetically available non-steroidal compound also which act as estrogen inside the body, and all this together we label them as estrogens. Estrogen endogenously release under control of pituitary gonadotropins. As discussed into the lecture of gonadotropin also, LH hormone stimulates the production of androgens, androstenediones and testosterone by theca cells of ovarian follicle. These two androgens are taken up by adjacent granulosa cells of ovarian follicle, and granulosa cell proliferate and express aromatase enzyme under the influence of FSH. This aromatase enzyme converts androgen into estrogen, estrone and estradiols. Aromatase is also present into the liver and adipose tissue, which will convert circulating androgens into estrogen. Production is This production of estrogen is unregulated, unlike gonads where production of the estrogen is under the regulatory process. As discussed in this previous slide, LH will stimulate the theca cells of the ovaries, which will release cholesterol, transform into androgen. Androgens are converted into the estrogen in the granulosa cell under the influence of aromatase, and this aromatase enzyme work under the influence of FSH only. So presence of LH and FSH both is required for the production and functioning of the estrogen inside the body. This synthesis of steroid you have learnt into the lectures of corticosteroid also. Cholesterol is converted into pregnenolone. Into the adrenal gland it is converted into progesterone, and then cortisol is produced. Pregnenolone will go to the ovaries or testes or gonads, where it is converted into progesterone, this progesterone is converted into alpha hydroxyprogesterone. This alpha hydroxyprogesterone will converted into androstenedione, which will be converted into estrone and testosterone will be interconverted into estradiol, and estrone will also converted into estradiol. Estradiol is the active form of estrogen inside the body. This production of the estrogen is under the control of the hypothalamo-pituitary-ovarian axis or hypothalamo-pituitary-gonadal axis. This we have discussed into the previous lecture of gonadotropins also, that ovaries will release estrogen and progesterone and also the enzyme inhibin, and the presence of estrogen and progesterone into the blood will send a negative feedback mechanism to the anterior pituitary that no further hormone is required. That is called as short loop inhibition. They will directly send a signal to the hypothalamus and inhibit the release of GnRH, that is gonadotropin releasing hormone, that is called as long loop inhibition, and also presence of FSH and LH will send a signal to the hypothalamus, which is called as ultra short loop inhibition, that no further sex hormones are required into the blood. So there is a three type of control mechanism: short loop inhibition, long loop inhibition and ultra short loop inhibition, and this will be controlling the level of estrogen inside the body. This also we have discussed into the previous lecture of the gonadotropin, physiology of menstrual cycle. Into the female genital tract, four cycles goes together. One is gonadotropic hormone, that is FSH and LH, ovarian cycle, ovarian hormones, and uterine cycle. So hormonal cycle, if we see, there is a into the pre-ovulatory phase there is a presence of FSH which is gradually increased throughout the phase, which help in development of the ovarian follicles, and these follicles will release the estrogen hormone, and the level of the estrogen will be highest nearly to the time of ovulation along with the LH surge, because Graafian follicle will release the estrogen hormone. Later on, because of the destruction of the Graafian follicle, estrogen level declines. Still, it is produced into some amount by the corpus luteum or into the post-ovulatory phase, where the progesterone hormone is produced in the larger quantity as compared to estrogen. LH surge is the process which will induce the ovulation for the female hormonal cycle. Simultaneously, into the uterus, changes are occurring that there is a menstrual period. Into the proliferative phase, uterine endothelium gets proliferated, and into the secretory phase, glands get enlarged and they become ready for inhibition. Glands become enlarged and secretion of the endometrium is so thick that it is ready for the implantation if pregnancy occurs. But if pregnancy does not take place, then estrogen and progesterone level falls down, which will lead to shed up of this mucosa and identified as a menses or menstrual cycle phase. Now we come to the estrogen as a drug. So classification of estrogens. First is natural estrogens, semi-synthetic estrogen and synthetic estrogen. Natural estrogens are estradiol, estrone and estriol and their esters. Semi-synthetic estrogen is ethinyl estradiol, and synthetic estrogen includes steroid, that is mestranol, and non-steroidal derivative which include derivative of diphenylethylene stilbene, that is silbestrol, triphenylethylene derivative, that is chlorotrianisine TACE, and these non-steroidal estrogen preparations are commonly used for treating carcinoma patients. Now we see how estrogen acts, mechanism of action. Estrogen acts through nuclear cytoplasmic steroid receptors. Estrogen receptors are of two varieties, estrogen receptor alpha and estrogen receptor beta. Estrogen receptor alpha are located into female genital tract, breast, hypothalamus, endothelial cells and vascular smooth muscles, while beta receptors are located into prostate, ovaries and brain. Estrogen receptors are present in different tissues and their response is varies based on the type of the tissue. Usually steroid receptor will accept this endogenous estrogen and form a steroid receptor estrogen complex that will form a conformational change and bind to steroid responsive elements on the target gene, which would lead to change into transcription and ultimately tissue function and modification according to the cell type on which the receptor is located is carried out. Basically, it is a nuclear steroid type of receptor. Actions mediated through cell membrane receptors are having faster onset of action like vasodilatation. Now we see the pharmacological and physiological actions of estrogen. Effect on the female genital tract. Estrogen is responsible for development of female reproductive tract, that is development of uterus, fallopian tube, vagina, cornification and stratification of the vaginal epithelium. Endometrial proliferation into the pre-ovulatory phase is mainly because of the estrogen. It produces rhythmic contractions of the genital tract and it makes the cervical secretions watery and alkaline so that sperm can easily enter. Deficiency of estrogen after the menopause will lead to atrophic changes into the female genital tract. Estrogen is also responsible for secondary sex characteristic development, usually which starts at puberty, development of breast, which include accretion of fat, stromal and ductal proliferation and ductal growth, feminine hair growth, usually axillary and pubic hair, feminine body contours, feminine voice, psychological and emotional get up, which is typical of a female, is basically under the influence of estrogen. Regression of acne because of the feedback inhibition of androgens. Another most important action is effect on menstruation. In women with deficient ovarian function in estrogen, it induces proliferative changes into endometrium. Following these changes, withdrawal of the estrogen will lead to menstrual flow and withdrawal bleeding. Not as a natural bleeding, which is usually because of the progesterone withdrawal, like we have seen into the physiology of menstruation, that into the post-ovulatory phase, progesterone is the main hormone and withdrawal of the estrogen and progesterone both, but mainly progesterone leads to menstruation. Response with the estrogen depends on the size and dose of the duration. Very small doses will produce irregular bleeding, can occur even without the interruption of the drug, which is called as breakthrough bleeding. Another action is gonadotropin inhibition. Continuous administration suppresses the release of FSH and also the mid-cycle LH surge that would lead to inhibition of ovulation. In males, if estrogen is given, it inhibits the spermatogenesis, and in testes, it induces atrophic changes and reduces androgen secretion. Administration of estrogen, even in larger doses after ovulation, does not affect the course of normal menstrual cycle. But this action, that is inhibition of ovulation, is the main action because of which estrogen is used as the essential component into contraceptive pills. One important action of estrogen is it also suppresses the lactation without affecting prolactin levels. Now we see the metabolic actions of estrogen. Estrogen is having weak anabolic action, which is responsible for pubertal spurt and epiphyseal fusion. Prolonged use of estrogen will lead to sodium and water retention. It can cause impaired glucose tolerance in high doses. It increases coagulability and fibrinolytic activity. It reduces plasma cholesterol but increases the triglyceride level, and it also produces biliary stone into susceptible individuals. It promotes the urate reabsorption from the proximal renal tubule. Lower mean 24-hour urinary urate excretion into the woman is seen as compared to men, which is said to be because of the estrogen. Larger doses of estrogen to children for prolonged period would lead to inhibition of growth of epiphyseal cartilage and early epiphyseal fusion, which lead to growth stunting into children. Now we see the actions of estrogen onto the bones. Estrogen produces positive effect on the bone mass. It enhances the osteoblastic activity as compared to osteoclastic activity. Both osteoclasts and osteoblasts have alpha estrogen receptor alpha and beta, but estrogen receptor alpha is having major role. Estrogen directly regulate the osteoblasts and promote their differentiation and enhance their action. It inhibits the osteoclast activity. It also inhibits the osteoblast apoptosis and survival of the osteoblast is increased. Decreased number and activity of osteoclast via altering the cytokine signals from the osteoblast is seen. It prevents differentiation of osteoclastic precursors into osteoclast. Increased osteoclast apoptosis is also seen under the influence of estrogen. Prevention of bone resorption by osteoclast is also seen. Another action is carcinogenicity. Estrogen is found to be carcinogenic into animals. It is implicated into genesis of cancer of endometrium, breast, liver and vagina into the woman. It is also having anti-androgenic action. Topical application of small amount of estrogen can counter the action of androgens on Capon's comb. Beneficial in prostate cancer, which is probably estrogen dependent. Now we see the pharmacokinetics of estrogen absorption. Estrogen can be given by oral, intramuscular and topical route. It is highly lipid soluble compound. Natural and synthetic steroids are absorbed through GIT, skin and mucous membrane. Almost all the surfaces can absorb estrogen. Orally, it is well absorbed. Natural steroids are destroyed by gastric acid and they undergo extensive first pass metabolism, also undergo enterohepatic circulation. Estrogen esters like benzoate and dipropionate are usually given intramuscularly, and these injections are absorbed very slowly from the site and they are effective for several days. So duration of action is longer with these esters. If we see the distribution, because of the high lipid solubility, they are widely distributed and receptors present into selective tissues only. Metabolism mainly occur into the liver by conjugation. Synthetic non-steroids are not metabolized much and excreted into the urine in free state. Excretion is usually occur through kidneys. 65% of dose is excreted into urine, 20% of which is estradiol and rest are the metabolites. Now we come to the adverse effect of estrogens. It can produce nausea, vomiting and GI upset. It can cause intermittent bleeding, headache, especially migraine can worsen. Blood pressure can be raised because of the retention of sodium and water as an effect of estrogen. Person may feel fullness or tenderness into the chest. Early fusion of epiphysis and stunted growth if the doses are given for prolonged period of time into children. It can produce teratogenicity also. Risk of thromboembolic disease is higher with the estrogen because it enhances the coagulability of the blood. Increased risk of gallstone and hepatoma because the drug goes into enterohepatic circulation. Increased risk of endometrial and breast cancer is seen with estrogen. It can produce gynecomastia and decrease libido into males. If we see the preparation and doses, natural estrogen and their esters, estradiol available as micronized preparation of 1 mg, 2 mg tablet for oral use and 1 mg per ml injection for intramuscular use. Estradiol is a self-adhesive estradiol transdermal patch which contains 25, 50 and 100 microgram of estradiol which is released per 24 hours for 3 to 4 days. But it should not be applied near the breast because the chances of breast cancer are high with such type of applications. Another salt is estradiol valerate available as 1 and 2 mg tablet for oral use. Estradiol benzoate injection 1 mg per ml, 1 to 5 mg is to be administered intramuscularly and effect lasts for several days. Estradiol dipropionate also administered intramuscularly, same route and dose as benzoate but once in 1 or 2 week administration is sufficient. Estradiol cypionate, undeconate and valerate, they are still longer acting, once every 3 to 4 week application is required. Estrol succinase 2 mg tablet and 2% vaginal cream is available and estradiol vaginal tablet of 25 microgram is also available. In short, you can see that estradiol is available for injection intramuscularly, oral tablet, transdermal patch, vaginal cream, etc. Semi-synthetic steroid estrogens are ethinyl estradiol available as 0.01 to 0.05 mg and mestranol which is a prodrug of ethinyl estradiol. Conjugated estrogens, mixture of numerous water-soluble conjugated estrogens, esters of estrone and equiline available as 0.625 to 1.25 mg to be given oral as oral tablet per day. Synthetic conjugated estrogen, Synastin, 0.625 mg tablets for vasomotor symptoms into menopausal women. Synthetic non-steroidal estrogens are diethylstilbestrol that is 1, 5 and 25 mg that is most potent. Quinestrol 100 microgram tablet, which is longer acting, and dienosterol vaginal cream, but synthetic steroids are mainly used for the cancer treatment. So, if we have to change between the steroids, then we should know the therapeutically equivalent doses. Here it is: ethinyl estradiol orally 5 to 10 microgram is equal to conjugated estrogen orally 0.6 to 5 milligram, which is equivalent to micronized estradiol 1 milligram, equivalent to estradiol oral 2 milligram, which is equivalent to estradiol transdermal 25 milligram. So these are the equivalent doses of different preparations, and if you have to switch over between the preparation, you should consider this. Now we see the therapeutic uses of estrogen. Estrogen is mainly used as a contraceptive purpose, as an oral contraceptive pill where it is combined with the progestin. Another most important use is hormone replacement therapy, which we are going to discuss in detail into subsequent lectures. It is also used for delayed puberty into female and amenorrhea, used for Turner syndrome, hypopituitarism, where it is given along with androgens and growth hormone. It can be useful for treatment of senile vaginitis and creurosis vulva, where topical estrogen cream is applied. For acne and hirsutism, feedback inhibition of androgen mechanism can be useful and estrogen can be given. Vulvovaginitis into children, ethinyl estradiol 20 microgram for 5 to 7 days cause cornification, growth of Dodeline's bacilli and lactic acid production, and ultimately it can heal the vaginitis into children. It can be used for the treatment of dysmenorrhea where NSAIDs are drug of first choice, but if it is not controlled, then one can start the oral contraceptive combined pills. Cancer prostate, where it is given as a palliative therapy where it suppresses the androgen production. Now we discuss anti-estrogen drug, that is clomiphene citrate. Till now we have seen about the estrogen, different types of estrogen, its mechanism of action, different physiological action and pharmacological action, therapeutic uses of estrogen, adverse drug reactions, pharmacokinetic, and all aspects related to estrogens. Now we start with the anti-estrogen. First drug is clomiphene citrate. Estrogen antagonism in all tissues is seen with clomiphene citrate. It blocks the feedback inhibition, so ultimately it causes raise into the FSH and LH level. It is a drug which is useful for the induction of ovulation, which is the main therapeutic use of clomiphene citrate. It is used for the female sterility where 50 mg per day clomiphene citrate is administered from 5th to 9th day of the menstrual cycle and can be increased. Addition of gonadotropin enhances the effect. It can be useful for oligospermia patients where it promotes the spermatogenesis 25 mg per day for 24 days with 6 days gap for 6 months. It is essential component of the IVF regimen where it is prescribed with gonadotropin for maturation of ova, and it is also one of the very important drug for the treatment of polycystic ovarian syndrome PCOD also. Adverse effect of clomiphene citrate are gastric upset, hot flushes, ovarian enlargement and acute abdominal pain, polycystic ovaries, multiple pregnancy because it is a ovulation induction drug. Risk of ovarian tumors is high. Another same drug is cyclophenol, which is structurally similar to clomiphene citrate, does not exert peripheral anti-estrogenic effect. 100 mg tablets, 200 mg twice a day for 10 days cyclically can be used for induction of ovulation. But clomiphene citrate is main drug for induction ovulation, which is nowadays very essential component of the IVF treatment. Next category of drug related to estrogen is selective estrogen receptor modulators, also known as SERM. They are not predominantly estrogenic nor they are predominantly anti-estrogenic. Till now we have seen estrogens, that is pure agonist, and clomiphene citrate, that is pure antagonist of estrogen. This is somewhere in between called as selective estrogen receptor modulator. As the name suggests, they are nor predominantly estrogenic nor predominantly anti-estrogenic. Binding to both estrogen receptor alpha and beta is there, but into selective tissues. Partially estrogenic in some tissues with anti-estrogenic effect or no activity in other tissue, which means the drug can combine with both the receptor, but at certain site tissue they are acting as agonist, and at certain site of tissue they act as antagonist. Example is tamoxifen and raloxifene. Tamoxifen citrate is considered as a prototype of drug. It is estrogen antagonist into cancer, breast and blood vessels where it produces hot flushes. Partial agonist into the uterus, bone, liver and pituitary. It stimulates the endometrial proliferation, reduces the LH and FSH and improves bone density and HDL to LDL ratio. It is first choice of hormonal drug for pre and postmenopausal cancer breast because it is acting as estrogen antagonist and it suppresses the cancer growth. Risk of endometrial cancer and male infertility is always there with use of SERM. Raloxifene is a partial agonist into bone and cardiovascular system, and it is antagonist into endometrium and breast. It prevents the postmenopausal bone loss into the women. It reduces the risk of vertebral fracture and breast cancer and decrease LDL. Adverse drug reactions are hot flushes, leg cramps and thrombosis. It is mainly used for the treatment of osteoporosis along with calcium and vitamin D supplementation into postmenopausal women. Ormeloxifene, it is an estrogen antagonist mainly into breast and uterus, and it is approved for use into dysfunctional uterine bleeding at the onset of menopause. Another category of the drug related to estrogen is aromatase inhibitor. If you remember, the function of aromatase enzyme is to convert androgen into the estrogens. So when we give aromatase inhibitor, they inhibit the synthesis of estrogen from the androgens. Drug is letrozole. It causes inhibition of aromatization all over the body. It inhibits the breast cancer more than tamoxifen. Adjuvant therapy after mastectomy into estrogen receptor positive patient is usually seen with letrozole. It is first line therapy in advanced cases. 2.5 mg twice a day is to be administered. Adverse drug reactions are hot flushes, nausea, diarrhea, bone loss and joint pains. Anastrozole, which is more potent, can be given as a single daily dose. It is adjuvant in early breast cancer and palliative therapy also. It can be useful for tamoxifen resistant cases, may respond with anastrozole 1 mg once a day. So this finishes all the drug related to estrogen. After completion of the progesterone hormone, we will be discussing oral contraceptive pill and hormone replacement therapy. I hope you have understood the session, and if you have any question, you can ask here. Thank you.